Thank you very much for joining us today at the start of Bristol Data Week 2024. This session has been organized by LEAP Digital Health Hub, and they're going to describe the contents of the session. I'm Patty Holly. I'm the manager of the Jean Golding Institute. I'm very, very pleased to introduce our first speaker, Hanna Isotalus, and she's going to talk to us about LEAP Digital Health Hub.
Yes, thanks very much for inviting us today to co-host this LEAP and Jean Golding Institute event on transforming health and care with data. So first of all, I'll give you a couple of words about LEAP, and then I'll hand over to my colleague Karen Dawe, and then finally we'll have our scientific talks after that, and we'll talk about what LEAP is and what it is like to bridge this gap in elevating digital health capability via upskilling. So first of all, LEAP stands for Leadership, Engagement, Acceleration and Partnership. So we are the Digital Health Hub here in Southwest England, and we also cover all of Wales. And really our core aim is to create new partnerships in digital health, including in health data science in the region. And in order to do this, of course, we want to have lots of collaborators. So LEAP is a joint effort between 5 local universities. So we have University of Bath, Bristol, Cardiff, Exeter, and University of West of England as our partners, as well as Health Data Research UK. And on top of that, we've also got 21 different companies nationally, 12 English NHS trusts, Welsh NHS health boards, some social care organisations, local authorities, business incubators, and Health Innovation West of England on board as well. And this list is growing, so we are always looking for more people to participate in our activities and getting involved in digital health in the southwest of England and Wales. So I'll put a link to our mailing list into the chat before the end of the event, so you'll be able to join our mailing list from there if you are interested in doing so. So to that end, today our speakers will include the 5 of us. So you will get 3 speakers from Bristol, myself, Dr. Karen Dawe, who's also a lecturer in digital health, Dr. James Pope, who is a data scientist working here in Bristol in engineering maths. And then we have Professor David Ellis, who's a behavioral scientist in economics in University of Bath. And then we have Professor Paul Harper, who works in operational research in Wales, and they will all be telling us a little bit about their research. So without further ado, we'll start with Dr. Karen Dawe, who's also the Deputy Director of Skills and Knowledge for the Hub. And Karen, I'll hand over to you if I can stop sharing my screen, and you can take over from there, please.
Thank you, Hannah. Okay, so as Hannah said, I am a lecturer in digital health, and I am also the Deputy Director for the Skills and Knowledge Programme that's part of the LEAP Digital Health Hub. And what I want to talk about today is the importance of having people work with data who know what they're looking for. We're living in a time when we have access to collections of huge amounts of data, but that's only valuable if the people who are working with it know what they're looking for. So I'm actually really thrilled to be talking about this for the Jean Golding Institute, because I'm going to use Jean's wonderful study, the AVEN longitudinal study of parents and children, to illustrate the importance of having people who know what they're looking for and what that means for health data science. I was actually fortunate enough to work for Jean's study for many years as a researcher, and most of what I know about the power of data to change lives comes from there. Professor Golding started the AVEN longitudinal study of parents and children, or You might know it better as the Children of the 90s in 1991. And throughout 1991 and 92, around 15,000 pregnant women in Bristol and the surrounding areas were recruited to the study. Jean is quoted as having said, at the time they were asked why we collected so many participants, and then later they asked why we collected so few. Jean was really a pioneer in this kind of broad approach in collecting as much data as possible at a time where it was much more common to use sort of very focused questions. Professor Golding has actually been asked kind of how she was able to push this concept through in the face of so much criticism. And she replied, oh, they thought I was mad for at least 20 years. But it was actually the Vice Chancellor of this university who was a mathematician and a statistician and understood the potential value and supported Professor Golding to push forward with this approach. And thank goodness. Data collected on the Children of the 90s study, which is still going today, includes all kinds of things: physical activity levels of children, blood samples from everyone, IQ scores, dietary reports, three-dimensional face scans, ball skills, menstrual cramps, air pollution, short-term memory, waist circumference, DNA, and my personal favourite, for anyone wondering what's in those buckets on the right there, those are placentas. So the original study was funded to follow the children, but it's since been expanded to include more data collection on mothers, fathers, grandparents, and of course now the children of the Children of the 90s. So this is social, psychological, clinical, genetic, biological data across 3 generations and counting. It's a huge amount of data, and it sits there patiently waiting for someone who knows what they're looking for. Huge amounts of data like this allow you to study things that are quite rare. Sudden infant death syndrome, or cot death, is thankfully fairly rare, but it's not rare enough, and it certainly wasn't rare enough in the 90s. Peter Fleming, a researcher here in Bristol, happened to read a Dutch study that suggested that putting babies to sleep on their fronts led to a higher risk of death, but there wasn't enough data. Fleming looked at the ALSPAC data, which found did have some of the data he needed, and along with additional data from Australia, Professor Fleming was able to confirm that 93% of the babies who had died had been put to sleep lying on their front. The findings significantly contributed to the government launching the Back to Sleep campaign. There were announcements on radio, TV, there was information printed on cereal boxes. The impact was huge. 2 decades ago, cot death claimed the lives of around 2,000 babies in the UK every year, and that has since been reduced by 80%. And none of that data was collected with cot death in mind. It took someone who knew what they needed to see the true value in the data, someone who fully understood the problem. Now, one of the first things collected was the placentas. Over the years, ALSPAC data has evolved into complex genetics data, synthetic to, and now sort of these days, even synthetic data sets. And thanks to the linkage team, it's being further strengthened by connecting it with external sources of data, such as primary care records and crime data. The impact of ALSPAC data on medical research has been huge. Data from the study have been used in over 1,500 publications so far on a huge range of topics. And these data are not collected with research questions in mind. They're collected knowing that someone who knows what they're looking for will come along, and the breadth of the data will allow them to answer their questions. Professor Golding at the time was revolutionary in her approach, but we live in a time now where collecting massive amounts of data speculatively is commonplace. So in the context of health data science, how can we make sure that we really realise the value of this data that can have a similar impact on health and care and the way in which health and care is delivered? What we need is people who know what they're looking for and can use the data to its greatest potential. People who know which questions need answering. In this regard, our greatest asset is our healthcare professionals. Their unique perspective on all this data is what can revolutionise health and care. They know what the problems are, they know the key questions that need answering, and will have a valuable impact on people's lives and how healthcare is delivered. And at this point, I'm going to hand back over to Hanna, who's going to explain the role of the LEAP Digital Health Hub in achieving this.
Thank you, Karen. There we go. Hopefully you can see that. Okay, so thanks very much for that, Karen. So as Karen said, this is one of the aims that we have within LEAP, is to really talk about and understand this kind of skills and knowledge partnership and transfer. So this is a bit of a complicated slide explaining the structure of the Digital Health Hub, but where this kind of training really sits is within our 3 core programs. So we have the Skills and Knowledge program that, as I said, Karen and I are leading on. Then we have a fellowship program and a research program. So in short, in the research program, we fund research in 4 core areas. So this is care outside hospital, frailty, fall prediction and fall prevention, clinical service and resource planning, and smart homes and smartphones and wearables for new therapies and patients management. You'll see some examples of what kind of research sits in these areas when you hear the research talks from Paul, David and James in a minute. If you are interested, if you're working in these areas, we do have a funding call coming up soon, so you might want to join our mailing list for that. This is our research program. Then we have the fellowship program, which is essentially looking at secondment. So we're looking at placing people from different industries within digital health and health data science working in other industries. So for example, if you're a researcher working in academia, you might do a secondment in the NHS or with a local startup, for example. At the moment, we have an executive fellowship call live, which you can find, again, details from our website. And very soon we will have further fellowships announced. So this is kind of looking at this kind of really getting hands-on experience and networking, working with other people in other industries and gaining skills that way. And then we have the Skills and Knowledge program, which is a comprehensive training program designed to really address the needs of industry, health and social care and academia. And here we have training delivered by each of our partner organizations. This consists of things like talks. So for example, today's event sits nicely in the Skills and Knowledge program. But we also have in-person short courses and workshops. So for example, there's a course on smart sensing that the University of West of England delivers. And then we have online continued professional development courses, such as the data mining course that is delivered by Bath University. On the other hand, we also have a course called Foundations of Health and Wellbeing that we deliver here in Bristol, which helps people who are working in data sciences learn about health sciences. So we kind of try to target people on both ends of this. Currently, we have 14 short courses and 1 long course bookable online, so you can find details of these on our website. But we are also continuously developing new courses and working on expanding our portfolio. And one of the examples of something we are developing is a course we're working on here in Bristol, which will be an online continued professional development course aimed at health professionals on AI. And we'll cover many elements of AI. We won't expect that learners on this course will go and program and build AI tools, but we will cover elements about ethics and how these could be practically implemented within the NHS. The image on the screen is AI generated. It came when I typed in a doctor working with AI. However, I think we can all appreciate that the reality isn't quite that glamorous. So I added in the NHS, and this is what it changed into. And so to this end, we are working together with people in academia who work in AI, but also with NHS doctors and industry partners in developing this this course so that we can really ensure that it's meeting the end user needs, so that it is realistic, so that we're not expecting this when the reality of technology in NHS looks more like this. I personally don't really see the AI element in this. So we really want to make sure that we're meeting the expectations of end users, we're being realistic, and can build that capability based on the reality of where technology lies today in health and care. I should say, I assumed this is NHS England, so then I next put in a prompt where I wanted it to be a very Welsh doctor working in the Welsh NHS, and this is what it gave me. I haven't spent enough time in Wales to know if this is accurate or not, but I thought that was quite nice. So to that end, when we have our learners taking part on our courses, so including the talk today, our learners become eligible to join the LEAP Alumni Network. And through this network, we will be advertising career development opportunities, such as the fellowships. We will offer learner certification. So if you sign up for this today, we can offer you a certificate of attendance for this talk. You will hear about networking collaboration opportunities. You will hear more about the research funding and then other training opportunities as well. So towards the end of today's event, I will put a link on the chat, and you can join the alumni network by putting your details into the link if you are interested in this. So that brings me and Karen to the end of our talk. We've got James Pope speaking next, but I believe we have a couple of minutes for questions if anyone has any questions at this stage.
Yeah, if you have any questions, please, you can type in the chat. So far, we don't have any questions. They just wanted to learn more about LEAP. So some people have got now the link to new newsletter. So that's good. And like I said on the chat, we are organizing a birthday celebration for Jean on the 11th of September at We the Curious. It's going to be a research event with really interesting talks. So I hope you can all attend and celebrate Jean's accomplishments. So yeah, I don't think we have any questions for now.
All right, thank you very much. And then I shall hand over to James Pope.
Okay. So my name is James Pope. I'm a lecturer in data science, and I've worked on a series of projects over the last several years focusing on assessing behavior in real-world environments, and I'm going to talk about a number of those projects today. So the real world is kind of in a sense, not the hospital, outside the hospital, outside of a clinical setting. So this certainly would include being at home, but it would also include being outside or being at work as well. And so one of the problems, at least when we're looking at an individual's health, is that at least with the typical way of doing this, you would have to travel, go to a clinical, be tested under some supervision. And of course, these are fairly infrequent snapshots of our health. And what we would really like is to understand our health in the real world. So I should also add there's also a benefit as well for clinical trials. Obviously, when they're looking at trials for example, for new drugs, understanding the health of a person in the real world will also be greatly beneficial. So as far as the behaviors, our activity, we, in some sense, as individuals, determine our behavior, and then those determine our activities. Much of the research focus is actually around assessing the activities and then determining the behavior from that. So you will hear this term often called human activity recognition. Obviously, a lot of the wearables now, the smart trackers and things like this do some of this and do some of it fairly well for certain activities. So we'll be looking at, of course, our behavior is related to certain health conditions. So we use a variety of sensors to do this. One common one, if in some sense it's a cheap way of doing it, are inertial measurement units. These are accelerometers, maybe a term that you've heard. And these are normally in the wearable. Usually if you have some type of wrist-worn wearable or something like that, usually you have these IMUs inside of that. And then we collect the data, and we typically these days analyze the data using machine learning algorithms. So on the right, you see a number of activities. Some are perhaps easier to assess than others. Some may be subsets of others, but I should say that some of these activities are in some sense entire research fields unto themselves. For example, sleeping, You can imagine other types of health issues related to that, also mental health as well. And again, some maybe in some sense trivial. I would say that much of what we're doing in the real world is there's a trade-off that we're looking at using these low-cost alternatives to gold standard measures, which are typically what you would get in a clinical setting. So there's some trade-off, and we're allowing some error, so to speak, accepting that, hopefully not much, so that we basically can get this continuous data, a large amount of data while people are living in the real world. The other thing to note is that the machine learning algorithms, they like a lot of annotations. Annotations are kind of, what are you doing? What activity are you doing? And you may have even trackers that periodically ask you and say, were you just laying down or something like that? What they're trying to do is get some annotations to help improve the algorithm. So this remains actually quite a challenge to do in real world environments. If I can go to the next slide there, whoops, make sure I didn't slip one. Okay, so I'm going to go through a series of projects or examples of where we have done this. One is on actually tremor severity, in some sense might be a involuntary activity that if you don't know, with Parkinson's disease, patients can experience tremors, particularly in their hands. And so you can imagine that, and what we did here is PD sensors. Kathy Morgan and Alan Wong headed this project that looked at people with Parkinson's and studied them over a 4-day period while they were living in a house. And so we used wrist-worn wearables to try to detect the tremor. Detecting the tremor in some sense has been done. As you can see here on the bottom, there's a tremor from roughly 752 to 753. We end up looking that in the frequency domain, but we detect the tremor. And really what they wanted to know was the tremor severity, because of course, the tremors get worse as the disease gets worse. To actually get the annotations to help the machine learning algorithms, we actually had the patients do self-annotations. So there's certainly research. That's an example of actually real world people living in their home environment and trying to gather this information to improve, certainly improve their life, and as well could also be used, for example, in a clinical trial to determine how well the medicine's doing. Which brings me to the next topic, Taurus. So Taurus was a follow-on. The previous project has completed. Taurus was a follow-on to that project. And what they're looking at in Taurus is to extend this over a longer period. And they're specifically looking at neurodegenerative diseases, including Parkinson's disease. And they're specifically looking at real world scenarios, looking at people's behavior in it, and they're really going after clinical trials to try to improve the efficacy of clinical trials so that they can determine whether a new medicine is working or not. So that's a collaboration. That one just started. That's a collaboration with Newcastle University. So I don't have too many results, just to give you some ideas of what will be done. There will be wearables involved. It may not just be wrist worn. There may actually be one on the lower back or in other places. But wearable technologies will be involved. Cameras will be involved. Certainly there are privacy issues, but certainly I'll talk about that later, how in some sense can be mitigated in some sense, as well as an annotation app and providing some machine learning looking at the data. So that study has just started. One thing that we're immediately looking at, which we know from previous studies is a problem, we actually knowing a person's location can really help you determine what type of activity they're doing. Obviously, if you're not sure from the data whether somebody is sitting or is laying down, but you know they're in the kitchen, well, they're probably more likely sitting, right? And so indoor localization has been studied quite a bit, and works quite well on a home that only has one level. Because next door looks for the, two rooms away look pretty far away. However, when you have multi-floor buildings, which we have many of those, upstairs actually looks closer than a room next to you. So way to obviously address this is using an altimeter in the device. And so certainly these are things we're currently looking at right now. I did mention sleep. This data was not one that I conducted or was part of, but certainly these are studies that have been conducted using IMU data to actually look at sleep quality, other measures of sleep. And so this was a Child Mind Institute study. And in this one, as you can see, over a multi-day period, the patients basically, or the participants annotated when they woke up and when they went to sleep. And as you can see, we can just take basically the magnitude of the accelerometer, and you can roughly see here between the red and the green, that's when they were sleeping. And from this, of course, you can derive total sleep as well as a number of other measures. And so certainly, as I had mentioned before, this is quite important for many different disorders and other issues such as mental health. Again, the actual gold standard is really the PSG that's typically done in a lab. So even though the IMU may not be ideal, we can get a lot from this, a lot of information about an individual's health while they're in the real world. Also, I'm going to talk, this study has completed. This is the URValve project, which actually was looking at individuals that needed to undergo heart valve surgery. So they went into the doctor and they basically had a loss of energy, activity. So they didn't have as much energy. The doctors determined that the cardiologist determined that they had a blockage, so they had to go in for heart valve surgery, an intervention. And so this picture here is in some sense on the y-axis is showing perhaps the activity level of the person. It's in some sense low. The little dot is kind of what we currently have. The person says, I'm just not have as much energy as I used to. And the cardiologist schedules an intervention. Nobody's better immediately after the surgery, so we would expect the activity to be less. But in the late recovery period, about 4 months later, we would hope, and this is in the optimistic case where the surgery was, the intervention was successful, that their energy or their activity is above when they actually before the intervention. And so what we did on the URValve project is we developed and I should say, we wanted to do something better than just these circle dots there, which are the snapshots. The cardiologist wanted to basically look at 2 weeks before, 2 weeks immediately after the surgery, and again, 2 weeks in the late recovery period to provide a more quantitative and continuous assessment of the person's activity. So we did that. So this is the kit itself. Again, the IMU is in this wrist-worn wearable. There's other stuff with the kit. The patients largely deployed this. And we also had some other stuff for the indoor localization, as I mentioned before, which helped with activity. And then we were able, this is a particular individual. We actually had 40 individuals partake in the study. This is one individual, and the cardiologists were quite interested in knowing room transfers. So how often were they transferring rooms? And with this particular individual, if you look in the upper left, maybe 60 room transfers before the intervention. Again, nobody's really great after a surgery, so it's a little less, perhaps around 50. And then in the late recovery period, we can see that they're quite a bit more active, around 80 room transfers, as they were called. So we're also able to provide more information as well as walking duration outside and sleep quality as well for this study as well. So, and this was also validated with clinical assessment. So this was a case of a successful intervention. I did want to, the last, in some sense, talking about sensors, I did want to talk about the camera data. Certainly, this is a privacy issue, but often I say that really what you want out of it is the pose information. So typically when we do these studies, we don't keep the video, we actually keep the pose information. And from this picture, you can see the little lines and dots are colorful. That's all that's kept. So you don't really keep the individual, you can't really identify the person so well. And so this can be used, but this actually gives quite a bit of extra information in some sense that the regular wearables can't get. So you can get certain other activities, time to sit, stand, turning angles, quite a bit more detailed analysis as far as gait is concerned. And certainly these techniques have been used for people that had undergone hip surgery and knee replacement surgery as well. This is a specific example looking at fall detection. I think we can also get this fairly easily with wrist-worn wearables. However, predicting falls is quite interesting. As Hanna said, that's something we're certainly looking at for future research. So to wrap up some of the problems, there's kind of a mismatch between real world and machine learning. The real world doesn't provide many annotations. Machine learning works really well when you have lots of annotations. So this is an ongoing problem. The other problem is the real world. If you have a home, perhaps kids, quite chaotic. We actually had a case where the downstairs for the participant was a pub, and the pub staff kept turning off the sensors. They kept cutting the power to the sensors. So you have to put up with these things. And also, many times the data is not going to leave the home. We don't assume that we're going to grab all the data and see everything, and we can run it on a data center with 4,000 GPUs. So we have to accept the fact that we're going to have to live with, in some sense, resource-constrained devices. So we'll need to be able to run these algorithms in a more optimal way. And I should say, one big problem, as that I had alluded to at the beginning, was how far are these low-cost alternatives from the gold standard? Can we bound it? You know, a lot of work still going on in this area. So in summary, that's hopefully that gave you an idea of the latest research happening around real-world behavior measurements, and can certainly, I think, a big promise to help us better understand individuals' health while at home and in the real world, as well as clinical trial efficacy. And that's it. That is my presentation. Any questions? Oh, I see a question in the chat.
Question there in the chat, yeah.
Okay, so the question is, are accelerometers you use for these trials commercially available or custom? If custom, what are the advantages over commercially available research-grade accelerometers, such as Active Power, ActiGraph? No, that's a great question. Generally, the accelerometers themselves, the actual sensor device is pretty much the same. So nobody goes and develops their own accelerometer. Normally what they do is they then put together their own board, right? Their own electronic, everything around it. I don't think that there's a huge difference between the actual accelerometers that we're using. We do develop our own custom not an accelerometer, we develop our own custom wearable at Bristol. And the advantage of that is we get all the data. Often with commercial devices, it's very hard to get the raw data, all of the data. So that's one of the advantages and disadvantages of having a custom PCB, for example, a custom wearable, is that we can ensure that we get all of the data and we can configure everything. Whereas for commercial devices, you can't always do that. However, there are, Activity is another one. There are companies that are providing devices that are a little better, that are commercially available, but better for researchers. And that has continued for some years, and maybe soon you could actually just use a commercial device for research purposes. So hopefully that answers your question.
Sorry, there is one more.
Yeah, so that one, we did do some sleep detection with an IMU. The other one is actually, if you go to the Child Mind Institute, actually the data that they collected is on, and the way that they collected it is actually on Kaggle, so they have all the details of explicitly which sensor was used to do that. I can try to get the link, but I don't have it offhand. I will just say that I think that most IMUs would be able to give you similar data. So hopefully that helps answer the question.
Thank you very much. And now, our next speaker.
Yeah, so I'm going to talk a little bit about, as the title suggests, digital data about patients. And this is work that's been going on for like 10 years, which is probably the longest collaboration I've ever been involved with. Very much in keeping with the ethos of LEAP. This work all started, so I'm not a medic at all, I'm a behavioral scientist. But this is work that started by sort of random meetings with people who are medics, particularly academic GPs, and also a reformed physicist. So it's sort of like, it's kind of one of those bar jokes where it's like, what happens if a physicist, a failed psychologist, and two medics walk into a bar? I don't have a punchline for that. But basically, this is what happened. And I mean, in terms of digital data, what this project largely involves the use of medical records, people's medical records. So, you know, interestingly enough, you can actually now access bits and pieces of your medical records now by downloading the NHS app. And, you know, many years ago, you know, medical records were all fully digitized and the world was going to be a wonderful place. And we'll just apply models to it and understand it. And actually, you know, exactly kind of what Hanna was talking about earlier, in that this project's only really been working well because it involves the people who actually create a lot of that data. Some stuff is automated in medical records for sure, but of course, ultimately, lots of that digital data is created by the people that you meet in the NHS. And without them on projects like this, I'm fairly sure none of this would have happened. So as I said, this is primarily about using that kind of patient data to answer questions, but also, as we'll come on to, the pitfalls and the pros of that, and also how that data can be linked to other types of digital data to understand what's going on. And specifically, this project's been looking at what we'll refer to here as missingness, which is often this idea of not so much just looking. So it's obviously important to look at how people move through systems like the NHS, but also what happens to people who move through and then disappear, or what happens when they drop off lists. And missingness is often referred to as this idea of people not taking up offers of care that potentially could lead to negative impacts. Some might view it as a health harming behaviour, but it could also be this proxy for other social vulnerabilities. And these were the sort of key questions that brought this team together. And obviously, as you can imagine, missingness is quite difficult to study in other kind of more qualitative ways, because how do you find people who are missing? It's actually really difficult, because if they don't turn up to an appointment, maybe they're not going to turn up to a research project either. So it was a case of thinking about casting the net really widely. And this is very much looking at both the patients themselves, but also looking at the system in which they sit in. So, you know, I'm going to talk about some kind of findings from different types of data, and just sort of what that's kind of told us about what goes on. And going back a long time, one of the first things whoever was involved in was looking at sort of seasonal or weekday patterns in when people do or do not turn up for secondary health care. This is actually a plot of every single missed appointment from across the whole of Scotland in a 3-year period. I can't remember how many million appointments it is. And one of the interesting things to hopefully notice from this is that irrespective of what speciality or gender, in fact, you tend to find that people miss more appointments at the start of the week than the end of the week. Now, that already, for the eagle-eyed among you, might suggest some sort of intervention. What's also interesting in that graph is that you'll notice that people who are younger, that kind of incline is much stronger than people who are kind of in the older part of the population. So if you were looking already to say, well, how might we maximize attendance? What you could try and do is shift more appointments towards the end of the week for the young patients, and potentially push more appointments to older patients towards the start of the week. So actually we did that about 8 years later. We had a clinic and we tested this, and we managed to improve attendance by about 30% in one clinic just by moving appointments to different days of the week. Now, that is fine for some people, right? But the problem with this data, beyond that nice outcome, is that it's aggregated. There's so much more going on for each person. There's so much more going on for each patient. Someone's age and gender is only going to tell part of the story, and this was kind of the beginning of starting to dig deeper. And rather than just look at this kind of aggregate data, well, can we get data from people, the same people, repeatedly? And this is what led to looking at medical records, because your medical records also record, particularly for primary care, when you've gone to the doctor and if you've turned up or not. Oh, by the way, another interesting trend you can look at from similar data is, believe it or not, I don't know if people know, but there's research that says that heart attacks, you're more likely to have a heart attack when the clocks go forward, and you're less likely to have a heart attack when the clocks go back. And interestingly, on a side note, you're actually more likely to miss medical appointments when the clocks go forward, and you're more likely to attend when the clocks go back, but that was just a side note. You can't really do much to intervene on that unless we're going to not put the clocks up forward or back. Anyway, so going back to sort of individuals, one of the things we looked at, so this is from about 800,000 people, and this graph on one side shows that obviously over a 3-year period, tons and tons of people don't miss any appointments. But there's huge numbers of people who are missing 1, 2, 3, 4, 5, 6 appointments. This idea of repeated missingness is a bigger issue than perhaps many people would think. And of course, again, you can start to look at both individual factors and system factors to see how you might improve that situation. Now, the graphs on the other side basically show, first of all, that people who are aged 16 to 30 are more likely to miss multiple appointments. But perhaps more interestingly, on a sort of slight political level, is SIMD stands for the Scottish Index of Multiple Deprivation, with 10 being the most affluent and 1 being the most deprived. What this shows, perhaps as a socioeconomic status often shows, is that people who are in very poor areas are more likely to miss more appointments. So if you've ever heard our current Prime Minister talk about charging people for missing appointments, that is one of the least evidence-based ideas that, and that's saying a lot, that the government could come out with. I'll get off my high horse now. But the other thing is that this data shows you is that you can also start to look at things, well, what about the delay between making an appointment and attending? And of course, you can see here that appointments that are made 2 to 3 days further down are more likely to lead to more non-attendance. So perhaps, and as we have seen since this work was done, actually, rightly or wrongly, many more GP practices are giving appointments out on the day. You can also look at other parts of the system to see whether it's being financially supported across the country. So one of the other studies we looked at was because you get a timestamp when you turn up at a waiting room, and you get a timestamp when you go into the doctor's surgery when you come out, you can actually look to see the differences in the time that patients are spending with their doctor. And you can look at that in affluent areas or deprived areas. Now, this graph is a little bit misleading, because when you look at this data, it looks like there's not an awful lot of difference between these different categories of people. But when you look at it within people and you control for, say, whether someone's age, the number of long-term conditions they have, you find that essentially people in deprived areas are actually seeing GPs for 14% less time than places in affluent areas. Now, that obviously raises interesting budgetary challenges, because it means that potentially to get the same level of care in deprived areas, you would need to increase the budget. So again, that's more of a system kind of potential challenge. I don't necessarily have a solution of that, because the money has to come from somewhere, right? But of course, the real power of medical records, beyond things like age, gender, socioeconomic status, is that you can start to quantify patients' complex health situation. Now, I think probably when I came into this work, I was a bit naive, because I just thought all this stuff would be logged there in a really nice, pretty way. But it turns out it's not. In Scotland, until recently, they used things called read codes. I have to confess, I'm not sure that stuff happens in England as well. Read codes are basically just code. For people who don't know, read codes are just what a doctor codes is wrong with you. But there's lots of different read codes that mean the same thing. So there's tons of read codes for a broken leg. There's tons of read codes for they've got a sore head. There's even a read code called God Only Knows, which is where the doctor has run out of ideas and puts that down. This is one of the reasons why you don't get to see those things in your medical records. So, part of the challenge in some of this work was actually coding, and people have done amazing work in how you can try and recode some of these read codes to get an idea of where someone's health lies from a physical and mental health perspective. And of course, one of the interesting things we then thought was, well, can we link this data? And one of the first things we did was we took people's, health conditions. The bits at the side there are just whether they miss no appointments, a small amount, a medium amount, or a lot. You can also then follow them up years later, and you can see, did they die or not? And probably one of the most striking things from this work is that people who are suffering from multiple mental health conditions, who are missing multiple appointments at the start, 3 years later are 8.5 times more likely to have died in a 3-year follow-up period. And on a slightly sort of serious part, I guess, is that they're dying from things that are almost always entirely preventable, because when you link this data, you can link it to the actual death code, and it's from the things that you might expect. So this is a bit of a red flag. First of all, there's an element here in predicting who might be in more trouble, but this also says that there are people, large numbers of people, who are dropping off the system and bad things are happening. So if that's a group that need extra support. And again, as I kind of said at the start, you can also link things like primary care to secondary care, and you can see, well, actually, is this a universal issue? If someone misses a lot of doctor's appointments, are they turning up in A&E? There's actually, again, a lot of political kind of rhetoric and some kind of commentary around people who miss GP appointments are using A&E as a GP. Now, we haven't been able to confirm that. In fact, we found that patients who had higher numbers of missed GP appointments were more likely to also miss outpatient appointments, and they certainly were not turning up at A&E, but they were more likely, once they were in hospital, to have what's called a regular discharge from inpatient care, so they weren't completing care once they were there. But again, some of this data really, really challenges some of the common rhetoric around, are people using A&E as a doctor's surgery? Not in this sample, anyway. We also have linked some of this to educational data. And this is part of this idea that missing this within health or missing this within social services more generally does not begin at adulthood. It may actually start much earlier on. And so this was perhaps more straightforward in Scotland, because Scotland only has one exam board, which helps. We were able to link a large chunk of this cohort to basically their school attendance, exclusion data, and attainment. And the results are kind of what you might expect. So patients who have got reduced school attendance also are going to miss more GP appointments as an adult. They're going to have been excluded more from school, and lo and behold, they have lower educational attainment. But this says that there's a kind of life course to some of these behaviours. The things that we're seeing in other social systems start at the point of school. And I suppose that's possibly even more relevant, given this was done long before things like COVID, where people were having to stay at home. This may have changed slightly since then. It may have got worse, it may have got better. But this idea that engagement with social services just kind of starts at adulthood, this kind of really challenges that. So again, that suggests if you want to do interventions, you might want to think about what's happening at school. And really that's kind of where this work is now moving, in that part of this work was to take digital data, try and make sense of it along with people who are creating and curating that data, to understand the problem. And now it's kind of a case of, and I've flagged these three things throughout, basically. You know, there's the potential to build new interventions. But also a lot of this work has started to push policy changes, because it's quite powerful to say, look, if you don't do something here, bad things will happen in a very kind of clear quantitative way. But I think it's also about, and then this kind of ties into LEAP as well, about building new digital tools to help people do this. Although I could have probably added at the bottom as well, there's policy around how you can more easily link data sets, right? Because data linkage has been talked about when I was a kid, and it's kind of, it's perhaps in my view moved more slowly than I would have thought it would, but things like LEAP of course will hopefully help speed that up. And you know, ultimately this is very much, a lot of this data, as someone said earlier, you know, is data that was all just out there, but it's kind of taken that narrow focus to say, well, what can we do with this? And of course you don't just help answer those questions, you also say, well, what could make this data better? Or what would we do differently if we were building a new system that could do something better? So if you want to read more about this work, you can, which is led by colleagues at Glasgow, you can go to missingthis.com. So yeah, I'll stop there, and if anyone's getting questions, I'll try and answer them.
Many thanks. Do we have any questions? Great, there's a question in the chat.
Oh, hang on.
Have a look. Okay, chat. Down on your.
Oh, there we go. I think about the patient-centered outcomes. How popular the code GP outputs? Same language. Yeah, so it's really challenging. I mean, there's a few. The way I'd answer that is that there's a limit as to what you can take, but there's probably more you could do now if you were doing this study again. There were things that we really wanted to code that we couldn't code. So one of the things we really wanted to do, and there's a really interesting paper, which is kind of like one of the most, I quite like it because it's a sort of failure paper, really. We wanted to try, and GPs obviously write tons of interesting notes, or they often write a lot of notes. And we thought that, I don't know if people are familiar with things like adverse childhood experiences, probably quite a few people know what I mean by that, but basically it's, you know, bad things that have happened to you potentially as a kid. And we wanted to see if we could automatically code that score from the data left in GP records. And we tried and we failed. But that was something we really wanted to do in this project, but we couldn't do it. So I think there's a question here about saying, well, you could code it, but GPs need to write more stuff. That's going to be difficult because they're obviously got tons of other stuff to do. So it's possible to code probably even more things, but I think the real potential here is if you could link some of this to stuff like Biobank, where you might have a lot of that already. You know, there's other opportunities to do it, but yeah.
Thank you very much. Let me see if there are any more questions. Any other questions?
I think the last thing I would say is that I think everyone often people ask about, like, oh, you know, how difficult was it to model this data and stuff, and I always end up saying that the actual running of the model was the easy part. There's just a few lines of code. It was the coding. All the code to do this is like all the pre-processing and everything. That's where all the huge amounts of time was spent. How much effort was to link those data sets? So technically, again, linking them is not as difficult as you think, because you often use things like dates. You know, you use like a probability matching link, and we had a data controller who kind of helped with that. So technically, it was all possible. I think, interestingly, it's probably worth noting that was one of the first, if not the first project in Scotland that linked some of those things together for the first time. I'm sure it's better now, but the policy side of it was the difficult one. Convincing various places why we wanted to link it when we didn't always know what we were going to find was probably the part that slowed it down. So actually, technically, wasn't that challenging. The policy kind of, you know, why are you doing this, was probably the bit that took the longest. And that's why, yes, so to answer maybe that next question, yes, we are, this project has now moved on to a more kind of qualitative phase at the moment, actually, looking at where we might go next in terms of developing interventions. But we've actually just finished a paper looking at attendance rates between people who've been diagnosed with ADHD using a case-controlled trial. It's worth noting that the funding for this the funding for most of what I've talked about finished a number of years ago, but we're still finishing projects because it was always running quite. Of course, LEAP won't run behind, but other projects we've been involved with have run behind, and so we're still producing papers now. which is quite interesting because we're having to negotiate access to some of the data sets again. But yeah, the current project, if you visit that website, you can see it'll actually, the missingthis.com link will take you to the current project, which is I've not really touched on here, but you can access the older stuff as well.
Thank you so much. Oh, there's one more. No, it's a
That was just a thank you.
yeah, it's a thank you. So now we have a new speaker, Paul Harper. Thank you so much, David.
Okay, hi everyone, and thanks for the opportunity to speak. And yeah, I'm your international speaker from over the water, over the bridge in sunny Wales. I haven't seen any dragon doctors, Hannah, but I think all doctors suitably qualified to be welcome here in Wales. So yeah, I'm a professor of operational research based in the School of Maths. And yeah, we've got a team here working closely with NHS Wales end users, trying to really help them understand healthcare systems in terms of service delivery and so forth, and trying to make sense of complexity using data science and analytics or OR techniques. Yeah, we know that healthcare systems are under great stress right now with increasing demand, issues around resourcing, and backlog of demand from waiting lists, for example, from the pandemic. And they also operate in very highly connected, complex systems, which are uncertain at times and high variability. I'm sure I don't need to tell you this, and you will know this yourselves, but if you want any proof, just take a look at this nice spaghetti bowl, which is a piece of work we were asked to look at some research about why do people attend A&E. So it's kind of actually nicely dovetails what David just talked about. So this is actually probably my most qualitative piece of work, which has been over the last few years, but it was trying to map out. So if you're familiar with kind of this technique, it's causal loop diagrams or system dynamics, trying to map out the kind of factors that influence people's intention to attend an A&E, and you can see it's complex, like health systems are broadly, and this is just emergency care, so it's not even elective care. So you can see it all, and if you can zoom in there a little bit on the bottom left hand side, it shows you the kind of balancing and reinforcement loops that go on inside that bigger system. So why perceptions about emergency departments, other people's experiences, can't see a GP, bypass GP, go straight to A&E and so forth. But you can see it impacts on primary care, community and health and social care, emergency assessment, secondary care. So it's a complex system. This is a very qualitative map to try to understand, and with the health boards here in Wales to try to hone in, if you like, on some areas where we can perhaps change behaviours. But when the government throws money at the problem like last winter, which is increasing A&E capacity by having porta cabins in a car park, you can see why simple solutions like that may be just sticking plasters, and the real problem is much more complex in terms of accessing services elsewhere. Trying to get people out of hospitals into community care is a real problem, for example. So it's a whole flow, a systems flow. So that's just a little taster really for some of the work that we've been doing here in Wales. And so we've found a particularly successful way to do this has been embedding data science and OR and a kind of researchers in residence type approach. So we're actually celebrating our 10th anniversary here with a team, that team on the left-hand side, of people of researchers, postdocs, PhD students, actually part funded by NHS health boards, part funded by the university, actually spending most of their week in the hospitals, in the clinical settings with managers and consultants, and some of their time in the university. So working between the university and NHS. So in some sense, they've been come to seen as like colleagues to NHS staff, which is great. So it's not about them and us, and it's not about ivory towers and so forth. This is practical, impactful work, hopefully, but being led by some innovative research ideas from the university side. We've also trained staff as well. That's a big part of our remit, and to actually deliver some of these skills to try to make this sustainable for the NHS staff themselves. We found this diagram quite helpful, and this is what we've been working with NHS colleagues in terms of what typically happens in the NHS is that we have, obviously, already other speakers have touched on this, as a wealth of data, vast amounts of data now routinely collected, but we often feel, the NHS can sometimes still be starved of information, lots of data, but actually making best use of that data. So, as you go from what happens a lot in the NHS, which is a lot of description in terms of reports and mappings and some diagnosis that takes place in terms of why did it happen, some statistical analysis, particularly on spreadsheets usually. We're trying to, push them on a journey to go through to prognosis, which is things like what will happen next. So machine learning, simulation, forecasting, and ultimately to optimization in terms of how do we get there. So planning ahead, optimizing, mathematical programming, for example. So this is a diagrammatic way, if you like, to try to express that journey. Very briefly, in terms of some methods, if you were to embark, for example, on an MSc course in OR or analytics, it's the kind of methods you would hopefully be taught. So we use a lot of discrete event simulation, so modeling individual patients through systems such as those in A&E and so forth, and they can be really helpful for looking at rostering staff, how many staff do you need on the wall, different skill mix and so forth at different times of day. So very operational type of tools usually. I've already mentioned system dynamics. That's some of the more kind of causal loop, holistic mappings of complex systems. We use game theory and some routing games, particularly when it comes to choice, patient choice around which kind of waiting list to join, and does it make any difference? Agent-based simulations in terms of they're useful for diffusion networks in terms of maybe in public health now, in terms of this is an example actually from adolescent smoking behaviors and friendships around that. And actually our work showed that, smoking behaviors form around friendships. Forecasting demand, optimization type methods, which I've got a little example coming up in a minute in terms of some of the complexities around how to best schedule resource, optimize your use of resource, which of course is a premium now in terms of the scarcity of resource, how you locate and allocate resources over a geographical region. And I've got another little case study coming up. And we've already heard from James about machine learning and data mining tools, which also are a vital part of the toolkit, if you like. A few examples of this, local and then more international. So a local one is working with the Welsh Government on a Cancer Research UK project in terms of a lot of data around diagnostic pathways for cancer. So here the problem really was around a timely diagnosis from suspected cancer to a decision either to start treatment or to downgrade. And it was unacceptable amounts of times people are waiting for that decision. And the problem is a lot of people are being navigated incorrectly through diagnostic pathways. So actually, the consultants thought that there were streamlined pathways in place. The Welsh Government wanted to bring in a single cancer pathway for different types of cancers. The reality was that there was a magnitude of pathways, and so we built some clustering methods to actually visualize pathways, to try to use that then for discussions amongst consultants to try to rationalize pathways into more meaningful a cohort of pathways, and then build simulation models to actually model that out. So in terms of, so this is the pathway for lung cancer, for example. Where do we need resource? Where are the bottlenecks in the current system? Can we introduce diagnostic hubs like one-stop shops, for example, for rapid diagnosis and so forth? So it's a whole lot of program in this area, making more use of the data to make better decisions. So the impact there was that at the time, the Minister for Health and Social Services here in Wales released some funding in line with the diagnostic capacity from our work. But also Wales introduced at that time also diagnostic hubs, as I mentioned, to try to speed up the time to diagnosis for some cancers. It's not every day you get to help design a new hospital. So we had that privilege going back the last 6 or 7 years, and the Grange University Hospital opened just outside Newport here, just in Cwmbran. We've done a lot of different work as part of that, but one thing in particular I want to flag up was this optimization methods, mathematical programming for some quite hard problems to do with theatre scheduling. So this is a problem that, of course, all hospitals have, and this is an example on the screen of a master surgical schedule, which tells you which specialty is assigned to which theatre on which day of the week. And the problem, though, is often that we have lots of cancellations. In fact, at Cardiff and Vale, at the University Hospital in Wales, when we started this work, every single day, roughly 1 in 5 patients who were scheduled for surgery had their operation cancelled on the day. So that's a huge traumatic impact for many people, not least the patient and their relatives. might have booked time off work. And the frustration really was actually when you look into the data, the reason why the patients were cancelled was not that there was no surgeon to undertake the operation, is there was no post-operative bed for the patient to go to after the surgery, so the surgery couldn't take place. So these are really interesting 3D type of timetabling problems, because you're looking at scheduling the allocating the resource on the day to surgeons, but also you're having to take into account how long the patient's going to spend in hospital beds after the operation, for example, in intensive care or back on the ward. So these are on the day and across the week trying to balance this. So there's lots of interesting, really interesting mathematical models that go on in terms of robust optimization, which we've been deploying to help actually create the master surgical schedule in the first place. And for example, in the new hospital, that's led to annual savings of 900,000 from improved theatre scheduling, whilst retaining the same throughput and actually reducing the cancellation rate. And my final example, just quickly, is something a bit further afield. So it's been a real privilege to have worked with colleagues in Indonesia on an EPSRC Global Challenges Research funded grant. So the context here is that when we started this work just before the pandemic, so we were rather disrupted, unfortunately, but we've managed to still achieve a fair amount, I hope, is that Indonesia does not have a unified ambulance service. So we take for granted here, of course, phoning 999, and hopefully an ambulance might show up. But with the pressures we have nowadays, maybe that's not always the case, not in a timely fashion, but it should be. But at least we have a 999 system, whereas Indonesia doesn't have a unified ambulance service. If you go to Jakarta, where we started our work, a population of around 12 million, one of the most congested cities on the planet as well, which doesn't help in terms of timely pre-hospital care. But there was a magnitude or a very disparate ambulance service with individual private providers for every single hospital. Typically, they were like 1 or 2 ambulances per hospital. They weren't really emergency ambulances. They were more patient transportation. And the idea of a paramedic doesn't really exist in that country as a profession. So this is what we really embarked on. So we've been working very closely with the Indonesian government and different stakeholders in Jakarta. We've done a lot of information and data gathering. We've looked at forecasting demand and tried to build some models of where you would actually place your vehicles optimally across a city like Jakarta. From a blank canvas, really. So how many ambulances do you need? What types of vehicles do you need? Where do you optimally locate these vehicles? And so forth. So just very quickly, if you're interested in the kind of mathematics behind this, traditionally we have response time targets like in the UK. So for the most critical patients, we would say an 8-minute target time, which is a little bit ironic if you think about it, because it's like a success is 8 minutes or less, and a failure is 8 minutes or more, and it's very hard target. So, I mean, if you arrive there at 8 minutes and 1, it might be a failure, according to the statistics that are kept, but actually maybe the patient survived, maybe that was okay. So actually what we've been trying to do is move towards survival curves, and there was some landmark work in 2008 around trying to build in some optimization with maximal survival. So trying to move away from minimizing response times to maximizing patient outcomes, which makes a lot more sense, right? We extended that work back in 2012 for multiple types of patients. The original work only had cardiac patients. We extended that optimization framework for different types of patients, but also allows a combination of hard time targets if you want to do that, as well as different survival curves for different types of patients. And the nice mathematical work for Indonesia has been to actually extend that again for different types of vehicles, which takes into account different speeds of vehicles, such as motorbikes or ambulances or other modes of delivery. So the kind of work, very quickly to finish off, is actually our model actually through, you say, for example, I've got money for 80 ambulances, and it would actually tell you where you optimally locate those across the city to cover the population. It takes into account, as I say, travel times and different demand predictions, and also different types of vehicles. So we've been also built this in simulation to try to test the robustness of this, and we're very passionate here about open source and available and sustainable software. So For example, if you're interested in this, we've built a queue discrete event simulation shell, which is available on GitHub and being published in the Journal of Simulation. So just to finish off, last slide, the impact to date. So it's been a bit of a journey with the Indonesian Ministry of Health, which has been a wonderful journey with our stakeholders. But we're now in a position 3 or 4 years after starting that work, that actually now Indonesia, based on a large part of our work, is actually now introduced across Jakarta, at least to start with, a unified 119 ambulance service. So for the first time in the country's history, they now have a go-to number, which is 119. You can see some pictures there of the types of ambulances that started to deploy. Our work showed the importance in particular of paramedics on a motorbike, because they can obviously get to the patient quicker and actually treat the patient on scene rather than trying to navigate through congested traffic to a hospital. We've done a lot of training as well. We've trained about over 150 analysts and local staff in some basic OR methods and data science methods, which has been a real privilege, and hopefully that will sustain the idea of use of these tools in Jakarta. And a big bonus and an unexpected surprise. Last time we went out, I actually had the honor of actually launching, if that's the right word, and if you launch a vehicle, launching an ambulance, which if you see on the bottom right-hand side there is named after Cardiff University School of Maths. So maybe we're the only maths department in the UK, or maybe globally, has an ambulance named after ourselves. But that was great fun. So that's it. So it's a bit of a whirlwind tour, but thanks for listening.
Thank you very much. That's amazing work, and congratulations with all the impact of your work. We have a few questions actually in the chat. Do you want me to read them, or you want to read it yourself? It's up to you.
Okay. Have you found any pros, cons with embedded data scientists in a larger team? Before, well, it's been now 10 years. Before we started on this, we would have like a postdoc maybe assigned to one hospital, or a PhD student funded by this hospital. And that worked well to a point. But I mean, the issue is, as soon as a student left or finished, or the postdoc moved on, a lot of the momentum also was lost. So I think I was pushing really for an embedded team, because I think, and also not just one person, but a team of people, because then they can support each other. And I think that's very important. And also by having a team as well, they can work on different timescale problems. So some people working mostly on longer term research, but also if they had to suddenly drop everything to work on a short piece of short turnaround time, they could also do that. But I think embedding has been really important, because then, as I said earlier, they're seen as colleagues. I guess the challenges have been that at times they've been pulled towards more consultancy style work rather than research work. And so it's been important to maintain our market in terms of what we do is research, primarily research and innovation work. And so the postdocs and PhD students are doing something which obviously interests them as well. So what are the backgrounds of your team? I mean, all of the postdocs and PhD students, no, I mean, they're mostly backgrounds are in, maths first degrees, or statistics or data science degrees, or graduates of our own MSc in data science analytics. But of course, again, the reason why this has been successful is that recognition. It's not just data scientists and the operational researchers in the team in the hospitals. They have to work alongside the right people in the hospital. So they have an improvement science team, for example, which brings together all people in as a key function in the hospital, which in terms of the people who handle the data, obviously there's change scientists, people who actually help implement the change, because after all, we're data scientists and we're mathematicians. We're not very good at implementing the changes ourselves. We can recommend to the health boards what they should do, and we can provide the evidence to do that, but that's somebody else's skill set entirely to actually implement that. Is there value in retaining NHS staff as data scientists? Absolutely. I mean, we come across, they're unfortunately quite rare, but we come across some super people who are, clinicians, managers who are passionate about and have knowledge of these types of skills. So I think, yeah, they are champions of data science and analytics. And I guess it's our job is almost to, to build that network of people who actually are using these type of tools. hence why we're also training staff in the health board. We run we just finished to finish off. We run a 1-year program with a cohort of about 10 managers in the NHS every year from different health boards who actually go through quite a comprehensive program and actually work on a project of their own choice in terms of their day-to-day job. So I think that's trying to build that kind of capability and capacity in the health board, which I think is also vital alongside the technical aspects.
There's another question here about when modeling beds in a hospital, do the models scale across different hospitals?
Again, that's a really good point, because yes, it's pointless to reinvent wheels. I mean, what's frustrating, I think, is that, you know, you've got people build the same models across different health boards, when these are the same problems at the heart of it. So a lot of the thing we're doing in Wales now through a network as well is to try and disseminate these types of tools across. It's silly to build so many different types of models when fundamentally they're the same types of problems. So if we can make them flexible, user-friendly decision-making tools, then the idea is that in principle, they could be picked up by any health board, any hospital indeed across the UK, and actually just kind of parameterized with their own data and used for decision making in their own area. There's no reason why you should have to reinvent models every time.
Yeah. There's another question. Somebody's wondering if your team is working on creating a digital twin of these physical models, such as hospital and ambulance, or if you have any plans to do this.
Yeah, well, that would be interesting to talk about. I mean, we've built lots of models, as I said, about with ambulance, not just in Indonesia, but also with Welsh Ambulance Service here in the past, in terms of this kind of deployment and forecasting and so on. I mean, to be a true digital twin would require real-time data feeds to then to disrupt and then to run forward. I think, and I think we haven't got there quite yet. Although in Wales we have now a national data resource, the NDR, which is quite an exciting venture, which is one nationwide repository of real-time data supplied by all hospitals. So the NDR is still in being built, but it's going to be deployed hopefully quite soon. So I think this real-time data streams opens up a huge opportunity for this type of work in terms of then sitting on top of that data lake, these types of decision-making tools. So digital twins, yeah, absolutely could become a reality in the future, which would be really fun.
Thank you. Another question. What software do you use to run the DES models? A lot of health economic models are in R, but many colleagues are still using Excel. So they're still learning.
Yeah, and again, really good questions, because as I said, we try to make our models, we try to make our tools, you know, open source, because a lot of NHS users can't afford software necessarily. Although having said that, NHS Wales does have a countrywide license for Simulate, which is an example of a discrete event simulation tool, which we teach our students here in university as well, because it's a fairly easy to use tool and actually get up and running quite quickly to build your own tools. But for the more complex stuff, or perhaps because we want to make it tailor-made with a kind of user-friendly front end, we would build, as I mentioned, we have this software called Q, CIW. Q is literally Welsh for Q. And the student who developed it, Geraint Palmer, who was my PhD student, now is a lecturer at Cardiff University. He's a Welsh speaker, so that's why the name. But I mean, so that's an example of built in Python. So a lot of Python work we do now, but again with a user-friendly front interface. So yeah, but NHS users still love to use Excel. So even, for example, optimization things, where we can, we will work with the tools that they're familiar with, absolutely. And if it requires, for example, an open source solver, optimization solver, which can be used freely alongside the Excel interface, then we would do that. We want to make sure that the end users are comfortable using these tools.
Thank you so much, Paul. Any more questions?
Great, thanks for the questions.
Maybe we can invite the other speakers, and if you have any other questions for the other speakers as well.
Thank you. I'll just take this opportunity to say that if you haven't been looking at the chats, I have put in there the link to get your certificates of attendance for this event and to join our alumni network as well. So please do fill that in.
I don't think I have any other questions. And as Hanna reiterate, if you want to receive your certificate of attendance, there is a link in the chat in forms.
Yeah, please do sign up so you'll find out more about the stuff we have been doing and will be doing. And I hope everyone is feeling just as excited as I am about the opportunity of data in health and care. I think we had a really fantastic range of speakers that really showcased the variety of things you can do in data to improve health outcomes for different populations. So thank you so much for the speakers and for everyone who's joined us today. And yeah, and I hope you have a lovely sunny
Sorry
week.
to interrupt. Only the last thing I wanted to say is we had a feedback form. So we're going to put the feedback form on the chat, and we will be very grateful if people can fill in the form. And we have a £50 voucher for one person. We're going to have a raffle for the people filling in the forms. And yeah, thank you so much for joining us, and I hope you can join the rest of Data Week. And thank you to the speakers. Thank you so much, Lee.
Thanks, everyone.
See ya.